My name is Matthew Kane, a recent graduate from Norwich Medical School and current junior doctor working in Essex. Thank you firstly to the Royal College of Radiologists for the 2022 Clinical Radiology Undergraduates Research Prize and for the opportunity to present the findings for my prize-winning project, volumetric analysis in post-hemorrhagic ventricular dilatation. This was completed at the UCL Great Ormond Street Institute of Child Health with the aim of optimizing neurosurgical management for this vulnerable patient group. So firstly, what is PH3D? Post-hemorrhagic ventricular dilatation, also known as PH3D, develops in 1 out of 4 premature infants with intraventricular hemorrhage. This represents the most common cause of hydrocephalus in developed nations. PH3D contributes to white matter injury, therefore is commonly associated with cognitive disability, cerebral palsy, and epilepsy. Figure 1 demonstrates a cranial ultrasound image of an infant with PH3D. Here we can see the markedly dilated ventricles as demonstrated by the ventricular index, or VI. The volumetric analysis is a technique which we can use to measure three-dimensional volumes of brain structures using MRI scans. These volumes can be used to identify potentially harmful factors, which can thereby inform preventative measures. In the context of PH3D, 2 studies have shown that brain volumes measured at term-equivalent age may be helpful in predicting long-term outcomes. So our project had 2 main aims. The first was to identify the factors influencing brain volumes at term-equivalent age among infants with PH3D. And the second was to explore the association of brain volumes at term-equivalent age with neurodevelopmental outcomes at 1 year and 2-year corrected age. So now moving on to the study methodology. This was a single-center retrospective cohort study. All infants were treated at Great Ormond Street Hospital between January 2012 and December 2020 in accordance with the local treatment protocol shown in Figure 2. As this shows, all infants with a ventricular index exceeding this threshold received up to 2 lumbar punctures, followed by a ventriculo-subgaleal shunt. The shunt diverts CSF away from the ventricles and into a potential space between the skull and the scalp where the CSF can be reabsorbed, as illustrated in Figure 3. So the demographic, medical, surgical, and neuroimaging data were collected using the electronic health record. The neurodevelopmental outcomes were retrospectively classified based on patient follow-up reports using a scale developed by Resch et al. This ranged from 0, which was normal development, up to 3, which represented severe disability. When looking at brain volumes, all T2-weighted MRI scans performed at less than 6 months corrected age were collected for each patient. An automated segmentation pipeline, as shown in Figure 5, was used to reconstruct the 2D MRI slices to form a 3D brain image, followed by parcellation of the brain components. We measured the lateral ventricle, cerebellum, deep grey matter, and total tissue brain volumes. On statistical analysis, we used multivariate regression models to predict brain volumes and neurodevelopmental outcomes. In the neurodevelopmental outcome models, any missing brain volume data was handled using multiple imputation, and sensitivity analyses demonstrated consistent findings both with and without the imputed brain volumes. So in terms of our results, there were 84 patients in our study. The majority were male, likely due to the higher rates of intraventricular hemorrhage in this group. All infants had bilateral IVH, while over 90% were classified as either grade 3 or grade 4 IVH. Now looking at the factors influencing brain volumes. Firstly, looking at lateral ventricle volumes. The median volume was 42 milliliters in our study. We found that the necessity for ventricular tap and lumbar puncture were associated with an increase in lateral ventricle volume. Conversely, antenatal corticosteroid use were associated with smaller lateral ventricle volumes. Now looking at deep grey matter volume, which comprised the thalamus and basal ganglia. We found the median volume was 24.8 milliliters. Furthermore, each additional day of intubation led to a 0.1 milliliter reduction in deep grey matter volume. Postnatal inotropes were also associated with reduced deep grey matter volume. Of note, the time from intraventricular hemorrhage to first shunt insertion was a non-significant factor, although was included in this model. Now considering the cerebellar volumes. So the median volume was 25.3 milliliters, and we found that sepsis and multiloculated hydrocephalus each led to a greater than 10 milliliter reduction in cerebellar volumes. And finally, when looking at total tissue volume, this comprised an aggregate measure of cortical grey matter, white matter, deep grey matter, cerebellum, brainstem, and hippocampal volumes. The median total tissue volume was over 300 millimeters. Each additional day of intubation led to a 1 milliliter reduction in total tissue volume. Furthermore, postnatal inotrope use and sepsis led to a reduction in total tissue volumes. Now looking at the neurodevelopmental outcome. So of note, odds ratio less than 1 favors a better outcome, whereas odds ratio of greater than 1 favors a worse outcome. So now considering outcomes at 1 year corrected age. We found that necrotizing enterocolitis increased the odds of adverse outcome by 17 times compared to infants without. Furthermore, porencephalonic cysts and male sex each increased the odds of adverse outcome by greater than 3 times. Deep grey matter at term equivalent age was not a significant factor in this model. So now looking at 2 years corrected age, intrauterine growth restriction was associated with a 10 times increased odds of adverse neurodevelopmental outcome relative to unaffected infants. Notably, larger deep grey matter volume at term equivalent age was significantly associated with a reduced odds of adverse outcome at 2 years corrected age. So to conclude, we found that intubation, inotrope use, and sepsis were each associated with smaller brain volumes among infants with PHVD. These promote systematic inflammation and cause fluctuations in cerebral blood flow, which likely account for these findings. Deep grey matter volume was associated with neurodevelopmental outcome at 2 years. However, the variables influencing this are not related to the management of PHVD. Time from intraventricular hemorrhage to ventricular subgaleal shunt insertion, however, was included in the multivariate model for deep grey matter volume. This suggests that shortening the time between intraventricular hemorrhage and neurosurgical intervention may preserve deep grey matter volume and thereby improve outcomes among infants with PHVD. Future work demonstrating the association of brain volumes with neurodevelopmental outcome beyond 2 years is required to validate the study findings. Higher resolution imaging is also needed to facilitate more detailed pastillation of brain components, including cortical grey matter. Thank you very much.